Good evening, everybody in Jacksonville. Say hello. Thank you very much. This is a Compass MS Care educational program provided by MS Views and News, and we do these Compass MS Care programs around the country every month of the year. Sometimes we add in a couple of extras just because there are regions out there that just need the educational programs that we are able to bring to them. Tonight's program, just to let you all know, we are supported by Bristol-Myers Squibb, Genentech, Sandoz, and TG Therapeutics. Let's let them know that we appreciate them. Thank you. Exhibiting here tonight, we had Alexion. We had Bristol-Myers Squibb, Novartis, Sandoz, Octave. You'll get to hear a little bit about Octave later on. TG Therapeutics and Viatris. So let's let them know also that we appreciate them being here. Thank you. Dr. Kalina Sanders practices at Baptist Neurology. She's board certified in multiple sclerosis and spasticity management. She's a native of Texas who fortunately came to Florida in 2006. Okay, and I could go on and on about Dr. Sanders, but again, we're short on time tonight, so let's welcome Dr. Sanders.
Thank you, Stuart, for inviting me to another MS Views and News to educate patients with multiple sclerosis. And so tonight I'm just going to share a few highlights on emerging therapies as well as biosimilars, and then a little bit about access to care and the importance that it is to be connected with your MS provider, whether or not it's in person or through telehealth. Told me how to do that. So this is our agenda for today. I'm going to jump in because I know we are short on time and really talk about some emerging and future therapies that we have available for up the road coming from multiple sclerosis. But before I do that, I think it's very important that I highlight really what the immune system does, because it will help to define how these emerging therapies are different from what we already have. So when we think about multiple sclerosis, we think that it is an autoimmune disease in which the immune cells out in the periphery, which make up your B cells, which are the blue ones, and your T cells, which are the red ones. But we also know that inside the central nervous system, you have innate immune cells, and those are called microglia. All of those are engaging in the inflammatory process that happens for multiple sclerosis. When we think about our known or are currently FDA-approved disease-modifying therapies, they have targets of the B cells as well as the T cells, but very few products actually enter into the central nervous system and impact the innate immune systems that are inside the central nervous system. So when we talk about the emerging therapies, there's a huge class of bruton and tyrosine kinase inhibitors, or BTKIs. There are 5 of them that are in current clinical trials for the management of both relapsing multiple sclerosis as well as non-active secondary progressive and and primary progressive. I will not try to butcher these names because they made it very hard, but I'm going to give it a try. Evobrutinib is being studied in 2 clinical trials for relapsing forms of multiple sclerosis. Tolebrutinib is looking at both relapsing multiple sclerosis as well as primary progressive and non-relapsing secondary progressive MS. Venobrutinib has 2 studies looking in active secondary progressive MS as well as in primary progressive MS. Orelabrutinib, that one's hard. 2 phase 2 studies looking at relapsing remitting MS, and remibrutinib, which have 2 phase 3 studies looking at relapsing MS. So the BTK inhibitors work by targeting the B cells that are out in the periphery, but as well as the microglia. Microglia is a cell that's inside the central nervous system that we have growing knowledge about the impact it has on progression in MS. There is a term called PIRA, and that is progression independent of relapse activity, which we have historically felt was due to secondary neurodegeneration that happens inside of the central nervous system. But we now know that that process is actually moved by ongoing subclinical inflammatory activity. We now call that smoldering MS. So we now think that it's not necessarily a neurodegenerative process, but an ongoing subclinical inflammatory response that is triggered by activation of microglia. So the BTK inhibitors, we know probably has some impact on inflammatory activity, but we're optimistic that they will have an impact on progressive disease. And that's why you can see in the previous slide, a lot of the therapies or clinical trials are looking at secondary progressive and primary progressive MS. What is the evidence that we have to date? Evobrutinib was looked at in a phase 2 study looking at MRI activity, and it actually showed a reduction in the number of GAD-enhancing lesions and some difference in annualized relapse rates. They are involved in an open label extension study that showed continued efficacy and new safety. But I will interject that hot off the press as of yesterday, in their initial analysis of the clinical trials, they found that the drug did not meet its primary endpoint, which was to see if that it was more effective than teriflunomide. They actually found in their clinical trial, 1, that relapse rates were low, 2, that teriflunomide is a pretty effective medication, and that the evobrutinib was not superior to teriflunomide. This is the initial analysis, and so more to follow on the official results of their clinical trial. We also have some data with tolebrutinib. It is felt to be one of the BTK inhibitors that really do penetrate into the central nervous system. And in the clinical trials, they noted on MRI that it also reduced GAD-enhancing lesions, which, as many of you may know, is a strong marker of inflammatory disease and multiple sclerosis. It is also going on open label extension. Now, these medications are obviously not without potential side effects, and so our known safety and tolerability for these medications include upper respiratory tract infection, increased blood liver enzymes, and lipase levels. And in fact, tolebrutinib is also on hold by the FDA because of 2 cases of liver enzymes. Now, BTK inhibitors are not new not new drugs. They are used for other disease processes such as B-cell lymphomas and leukemias. So we know in other disease states what the potential side effects. So it's not concerning that we are seeing liver enzymes and somewhat expected, but still needs to be hashed out. Other side effects noted in the clinical trials were headaches. So more to follow on the BTK inhibitors. Does anybody know what GA is? Has anybody heard of GA depot? No. I'll say a word, Copaxone. Glutamer acetate. So there is actually a company that has produced a long-acting glutamer acetate that is given intramuscularly once a month. So any of you who have experienced daily Copaxone injections or 3 times a week Copaxone injections, now there is an option, potential option for a once a month glutamer acetate. In its clinical trial, it did show a 30% reduction in the number of annualized relapse rates compared to placebo. The company has submitted the application to the FDA, and they are due to hear back in March. So again, more to follow. This is another new, surprisingly effective medication for multiple sclerosis. It's called furoluramab. Furoluramab, I'm struggling with these words today, bear with me. They did it on purpose. I know they did. It is a monoclonal antibody that is actually given intranasally. It's given as a spray in this clinical trial 3 times a week for 1 week and then nothing for a week. They alternated it. It is unique in that it is targeting activated T cells that carry a marker called CD3. Now, CD3 is important not only because it helps to increase regulatory T cell activity, so the T cells that are there to help with decreasing inflammation, but it also has an impact on microglial and astrocyte inflammation. So again, maybe another potential marker for progressive disease. It has only been studied in 6 patients. This was kind of a point of concept study in which they had 2 patients initially, and then they were able to add on 4. So at this point, 2 patients have completed 1 year's worth of study. The other 4 have completed 6 months. And this study was also interesting because they actually used PET scans to identify the activity of microglia. And they found that after the intranasal administration of this therapeutic option, it decreased the amount of activity in 5 out of 6 patients. And then they measured some clinical activity as well, including EDSS. And 2 patients had a decrease in their EDSS score, so that means improved function, and 4 remained stable. So this is an interesting slide that really shows the amount of baseline microglial activity. Again, this is the activity that we think is important in smoldering MS or progressive disease. And you can see after 3 months, the levels of microglial activity decreased in all of the areas on the PET scan. Now, most of our drug therapies that have been evaluated did not look at PET scans for their involvement of microglia because they did not feel that they actually entered into the central nervous system. So more to come on that. They are looking to start a phase 2 study, obviously with more patients, to again hash out the efficacy and the side effects of the medication. So let's switch gears and talk about biosimilars. When we think about biosimilars, many of us start in our mind to think about generics. This must be another type of generic. But I think it's important to know that biosimilars are not generics, and they can only be developed on biologics. You might be wondering, what is a biologic? A biologic is a therapy that is created based on a live organism. So many of our disease-modifying therapies are chemicals. They are created from different amino acids or organic structures. But medications like natalizumab are actually started by live organisms. These could be bacterial, viruses, and they grow them and then they target them to a particular target. So when someone wants to replicate a biologic, they cannot necessarily take their original cells. They have to create their own cells. So the FDA approval process for biosimilars is much different than it is for generic medications. And so really what they have to do is go through this 4-step process where they have to characterize their reference product. They have to understand what cells are used, how can they impact the immune cells. Then they have to kind of develop the manufacturing process of their own cells. And then they have to establish a similarity. And before that, they do have to do a clinical trial for it to be FDA approved, which is somewhat different than generics, in which they only have to show that they are pharmacologically similar, but don't necessarily have to show that they're clinically similar. So the process is much different for our reference products, where the analytical process is a very small process. A lot of the information is gathered in clinical trials, phase 2 and phase 3 studies. When we're looking at biologic development, a lot of their effort is in the analytical part of it, and then the clinical trial is really what tops off their data. So there was a biosimilar approved in August of this year, Tyruko. It is a biosimilar for Tysabri or natalizumab. It was studied in a phase 3 trial comparing itself to natalizumab, and over a 24 and 48 week period, they found that there was similar reduction in annualized relapse rates. They also found that disability progression, although very minimal, was the same between the natalizumab group and the Tyruko group, and that they also shared similar adverse events or treatment adverse reactions. And so that's what I have here on this slide, is that the orange is the natalizumab group, and this is the number of new gadolinium enhancing lesions on the MRI, and the blue line is the Tyruko or the biosimilar. And as you can see here, they are very similar in the impact it has on MRI activity. Now, you might be wondering, what about the risk for PML? And the company does understand that that risk exists. The FDA did require that Tysabri have a REMS program, and Tyruko also has a REMS program. They are developing or have developed their own JC virus assay. And from what I've been told, that if there's someone that is switched from Tysabri to Tyruko, that there will be a crosstalk between the portals where that information, including JC virus status, the number of infusions, will be shared between both of them. So those are our emerging therapies. And so I'm going to switch gears very quickly and talk about neuroplasticity. And I think this definitely kind of blends in with what Jeff was talking about earlier, and the benefits of physical activity and movement on our central nervous system. So as you can see here in this beautiful picture that I found, that the nervous system and the nerve cells are an intricate network of axons and nerve cell bodies that communicate with each other and tell our bodies what we're seeing, what we're feeling, and how we're walking and balancing ourselves. And in someone who has multiple sclerosis, there is damage to that area. And so you're left with a potential deficit, again, vision loss, weakness, or ataxia. But through things like physical therapy and other healthy lifestyle modifications, the brain does have the ability to have neuroplasticity. And essentially what that means is that the nerves can either reroute themselves. So here the blue line is the primary pathway to get that function done. The red lines are the secondary pathways. And so if someone has a block in their primary pathway due to an MS plaque, the brain can now take one of those secondary pathways, make it the primary pathway so that that communication can get where it needs to go. The other option that it has is sprouting. So again, you have nerve cells that are communicating to each other. If one is blocked or dies, the brain and the nervous system has the ability to sprout new connections with other nerve cells. But it can't do that unless it's been told to do that. If we think about how we are developed once we're born and we're going through toddlerhood, we are walking, we are moving, we're engaging with the environment, and that's how our brain grows initially. So quite basic, we would expect that to happen when we're talking about neuroplasticity. So a lot of what Jeff was talking about is extremely important. The level of movement is not as important as the type of movement. So if you can only do 5 minutes of physical activity a day, that's better than 0 activity a day, right? And that gives your brain the opportunity to say, hey, I really need to take over that function. Let me reroute or resprout. out. And that's not only physical, but also mentally and cognitively. So you definitely want to do things that help to keep those wheels turning, doing crossword puzzles, word search puzzles, luminosity. All of those things can be helpful to, again, teach your brain to reroute and resprout. Does that mean it will go back to being perfect? No, but there are many people, and some here in the room maybe, where you've had a level of functional disability for a period of time, and you've actually noticed that you've gotten better. I had one patient that spent years in a scooter, and then she said, "Hey, guess what I can do? I can walk now." I think she's in this room. So physical activity is extremely important. Cognitive activity is equally important to, again, keep things moving. All right, I'm going to finish my talk really talking about access to MS care. And one of the themes of Stewart's MS Views and News Compass to MS Care is really reaching out to rural America and underserved communities. And although we are in a bustling metropolitan type of environment, there are still areas that are underserved. Health determinants is one aspect of our lives that really has an impact on our level of function and our ability to maintain our level of independence. We think about the actual disease process as being one part of how well we function, but the things that we engage with in our lives also has an impact on our level of functioning. And so when we are looking at a person with multiple sclerosis, we're really looking at their entire makeup, their entire profile. And so I do care about whether or not the social economic status is there to help to make sure that you have access to your disease-modifying therapy, or you have access to come and see me, that you have the education so that you are knowledgeable to maintain adherence to your disease-modifying therapy, and that your physical and social environments are safe and there to help to support you. Many of you have caregivers in here that are or support partners that are there to help to make sure that you remain functional. But one of the key ones is health services and access to the correct doctors. So we know in underserved communities that there is less access to MS care than we see in other communities. In one study that looked at in underserved communities, and oftentimes these are Black and brown communities, that 56% of African Americans had never seen a neurologist that specializes in multiple sclerosis. 47% of Latino Americans never experienced or had involvement with an MS neurologist. And 50.4%, and particularly in rural America, had no access to an MS specialist. And if you look at an MS clinic, even fewer patients have received care in a center like mine and Megan's. And unfortunately, 64% are less likely to use case management and have those social support that are needed. And 48% are less likely to have nursing services. And so there are many reasons why there is this discrepancy in rural and underserved communities. There are numerous of them, but I've highlighted a few. Lack of transportation, an uninsured or underinsured status, income deficiencies, as well as low health literacy. So what is access to care, and how does it change versus in-person and versus telehealth? I think the COVID pandemic really helped to expand our healthcare access to patients who are in rural and underserved communities. Telehealth is not new. However, there was a lot of restrictions on our ability to use it before the pandemic. And since then, it really has opened up our doors to patients that could not physically, due to lack of transportation, get to a healthcare center. And so I think it's important that whether you are in person or through telehealth, that you reach out and you stay engaged with your healthcare provider. And with that, that concludes my time. Thank you so much for your attention.
That's great. Thank you very much for that. So, who's got a question? And don't be scared about being the first person to ask a question. Oh, no, we're not doing questions yet. Sorry, I messed that up. Thank you, Megan.
I was ready to stay here and go for it.
Oh, my gosh. See, I'm having a rough year. Thank you. Oof. Boy, am I glad you cut me off. All right, so unfortunately, I don't have a script from Megan, but Megan's got everybody knows Megan, right? Raise your hand if you don't know Megan. Awesome. No, time for you to go home then. There you go. I'm just going to let Megan take it away, although I can say that Megan Weigel has been doing a tremendous amount of things for MS Views and News over the years. We greatly thank her for that. She's on our original board of medical directors, and I thank her for that as well. And she's here today to speak with you about treatment options, specific symptoms, biomarkers, and a few other things. And I'm just going to let her take it away, and let's get started, okay? Thank you. Thank you.
I'm going to say that about 10 years ago, I probably would have been afraid to talk back to Stu, but now I'm not. I would have been afraid to talk back to you about 10 years ago, but now I'm like, that's not on the program. So thank you guys for being here. It's a really busy season. It's so great to be spending 12 hours a day with Dr. Sanders. And it's so great to get to go to work with my friend every day. So it's really fun to be here with her. So yes, I'm going to talk about symptom management. I'm going to talk about biomarkers, and I'm going to try to wind it all together with the other things that we've talked about tonight. And I think that we can do that. So appetizer tonight is just quick background info on MS. You've heard it, you know it. Main course is symptom management with a twist of integrative medicine. And the dessert is biomarker tests, including MRI, and how we use those in MS. So you guys know what MS is. It's an autoimmune disease. It causes demyelination in the central nervous system, which you've also learned can, re-sprout or reroute. I love that. Who gets it? Around 1 million people in the US have it. There's 3 to 4 women to 1 man who has MS. We now have data that says it's probably equally as common in Blacks as in whites, or nearing that. What causes it? We don't know. Low vitamin D, smoking, a history of mono and obesity in adolescence increase the risk. That smoking and low vitamin D isn't in adolescence. It's just the mononucleosis and obesity. There is that Epstein-Barr virus link. That's the disease that, or the virus that causes clinical mononucleosis. It's treated with disease-modifying therapy, relapse management, and symptom management, which I get to talk to you about tonight. I'm going to roll through these common symptoms of MS. I picked these out, but I think if you were to look them up in a book, you would find that these are the most commonly reported symptoms in MS. There are a lot of other symptoms that roll into these. For example, neuropathic pain and spasticity can be associated with weakness and sensory loss. I didn't have balance on here, but we're going to weave balance into a lot of this as well. So let's start with fatigue. If you're comfortable raising your hand, tell me how many of you who have MS experience fatigue. Okay, I was good picking that symptom, right? So fatigue isn't always caused by MS. And when your healthcare provider takes a look at you, even if you've had fatigue for a long time, let's say it's getting worse, or if you didn't have it early on and now you have it, we don't automatically say, here's your prescription for MS fatigue, because actually the medicines for MS fatigue, as some of you may know, don't really work that well. They're not that awesome. We look for other causes first. So is your thyroid working okay? Are there any vitamin and mineral deficiencies that we need to correct, like vitamin B deficiencies or iron deficiencies causing anemia? Do you have a sleep disturbance? Could this be depression? The literature with fatigue and depression is kind of goes like this, as a seesaw with what comes first, fatigue or depression. And it's, I think you could read one article and decide that, well, yeah, depression could make me fatigued. And you could read another that says, well, yeah, fatigue could make me depressed, right? And then medication side effects. So the medications that we prescribe to you for other things that MS causes, I would say about 80% of them list sedation or sleepiness as a side effect. So what are we going to do about it? Well, we're going to check you for those things, and then we're going to offer you medication or adjustments to your medication. And the medications that we typically use to treat fatigue are things like modafinil and desmodafinil, which are Provigil and Nuvigil, amantadine, amphetamines, potentially antidepressants like bupropion, Wellbutrin, or Trintellix, and possibly dalfampridine, which is the generic for Ampyra or Ampyra, because if we can help you move a little bit better, then we may conserve some energy at the end of the day. We can also refer you to occupational therapy to help you conserve energy, physical therapy to help your body get a little bit stronger, and again, learn how to conserve some energy. And so that's, the conventional style of treating fatigue. So the integrative piece adds in the same thing. We're looking for the same things, but we're also maybe talking a little bit more about diet and hydration. How many of you have noticed that when you're dehydrated, you're more tired? You got to water yourselves, little flowers. It's very, very true. You perk up. How many of you notice that when you eat really crappy food, excuse my French, this kind of happens? Too much sugar, too much, a heavy meal, lots of butter and cream, Thanksgiving, right? Who's awake by 9 o'clock on Thanksgiving? It's not happening. The problem is that happens at very frequent meals for a lot of people. So talking about diet and hydration, getting things out of your diet that might be contributing to fatigue, putting things in your diet that actually help your cells work better, developing goals for daily movement and exercise, just like Jeff was talking about. You've got to have goals, encouraging daily time spent outside because natural air, sunshine makes people feel better. And then considering a supplement called acetyl L-carnitine, which I wouldn't recommend you take without talking to your healthcare provider. But there's old studies that suggest that acetyl L-carnitine works just as well, if not better, than amantadine and Provigil without the side effects. And then considering something called low-dose naltrexone. How many of you have heard of low-dose naltrexone? How many of you have heard of naltrexone? Naltrexone is a medication that's used to block the opiate receptors. And in low doses, it is thought to help with fatigue, help with pain, potentially be anti-inflammatory, but that's theoretical, not proven. So let's move on to cognition. Cognition and fatigue have a lot in common. Causes of cognitive issues are similar to causes of fatigue if they're other than MS. So thyroid dysfunction, vitamin deficiencies, sleep disturbances, medication side effects, depression and anxiety. And you'll see depression and anxiety pop up a lot in these symptoms because pain, depression and or anxiety and memory compete for the same on-ramp into the brain, and memory always loses. So let's say you're pressed for time, you're in a hurry, and your partner calls and says, hey, what's blah, blah, blah's phone number? And you're like, oh, because you can't get it. You're in a hurry, you're anxious, you got to get out the door. You can't remember that thing. So again, all of those things compete for the same on-ramp in the brain, and memory always loses. We send you for neuropsych testing. You're having some cognitive issues, a mini mental status exam in the office might not be the best way to get at what's really happening in your brain because you can pass it. You might have a 30 out of 30, and that doesn't tell us that, gosh, you're having trouble learning new things or you're really having a hard time multitasking at home. So we send you to the neuropsychologist. The neuropsychologist does a long battery of tests that not only helps us figure out where your deficits are in different parts of cognitive function, but also based on how you score can tell us whether this is related to MS or not. Maybe it's related to pain. Maybe it's related to a mood disorder. Maybe it's related to medication side effects. Maybe it's a little bit of everything. And then we would refer you to cognitive rehab. Have any of you done cognitive rehab before? Okay, so cognitive rehab is like physical therapy for your brain. You work with a speech therapist, and in my experience, people with mild cognitive impairment have the ability to, you don't have Alzheimer's dementia. You have the ability to learn new things and to improve the function of your brain through rerouting and resprouting. So cognitive rehab is like PT for the brain. You see yourself get better. You do your homework. It's like conjugating French verbs. It sounds horrible, but you get better and faster and it feels good, right? Just like when you finish physical therapy and you meet your goals, it feels good. So if we're looking at this from an integrative standpoint, we're just adding in a little bit more. We're discussing those basic tenets of brain health, and we're helping you make lifestyle modifications to improve that brain health. And that in turn improves neuroplasticity. And guess what else it does? It makes that connection between your gut and your brain work better so your microglia behave. Now, we learned about microglia also in Dr. Sanders' talk about the BTK inhibitors. We're primarily trying to affect how microglia work in the brain. Are they pruning well? Like, think of your yard. You have the lawn guy come, or you like pruning your bushes and everything looks nice. When microglia misbehave, it's like Edward Scissorhands gone wrong. And that's what happens in the brain and is probably one of the reasons why you have cognitive loss. So by healthying up your diet, moving your body, getting you engaged socially, managing your stress, helping your sleep, training your brain to learn new things, maybe a language, maybe a creative art, maybe an instrument, and then managing other medical conditions that might affect your brain, we can help improve your cognition. So I found this cartoon, and then it was copyrighted, so I made it new. So I thought it was really cute. So now we're going to move on to neuropathic pain. Pain is a doozy, no matter how you look at it. Pain in MS can be primary, which means it comes from an MS lesion. An example would be a Lermite sign. So you have a lesion in your cervical cord, you tip your chin to your chest, and you get that lightning bolt down your spine. That would be primary MS pain, or pain when you move your eyes if you have optic neuritis. Secondary MS pain is pain that's caused by a problem that MS causes. So an example would be having lower back pain because of the way you walk from weakness in MS. No matter how you look at it, pain doesn't feel good. Neuropathic pain specifically is nerve pain. So when we treat that, we assess it. How bad's your pain? What makes it better? What makes it worse? We treat it with medications, typically anti-seizure medications and antidepressants. And then we refer to pain management very frequently for interventions like opiate therapies, injections, maybe even stimulators, spinal cord stimulators or pain pumps. I'm going to talk about spasticity in a little bit, but a baclofen pump is available to treat spasticity. In integrative medicine, there's more that we recommend. So again, assess pain, assess your nutritional status. Overweight and obesity is actually an inflammatory condition in the body and can make pain worse. Low-dose naltrexone may help with some types of neuropathic pain. We recommend mind-body therapies. So there's very great evidence for guided imagery, mindfulness techniques, and biofeedback in improving pain. And also very good evidence for manual therapies like acupuncture, acupressure, massage, and forms of energy medicine like therapeutic touch and Reiki for improving pain. Bowel and bladder dysfunction go hand in hand, and obviously they're in the same area, but I don't think a lot of people realize how significant one can affect the other. So conventional treatment of these is typically we talk to you if you're constipated, which is the most common type of bowel dysfunction in MS, about increasing your fiber and your water. You can't do one without the other. If you increase your fiber and you don't drink water, you have a big brick in your stomach. So you can't do one without the other. Stool softeners, bowel stimulants, referrals to GI are things that we typically do for bowel dysfunction. For bladder dysfunction, we refer to pelvic floor rehab. We prescribe medication, and there are very few bladder medications that don't potentially cause constipation, which is interesting, but they do help. They are helpful. And then we refer to urology for things like Botox, bladder stimulators, perhaps even surgical procedures. For women, MS isn't the only cause of bladder dysfunction. So you may have pelvic floor prolapse or bladder prolapse from having babies and things like that. So sometimes a mechanical problem just makes the MS problem a little bit worse. From an integrative perspective, and often in a regular office visit, this would be recommended as well. We talk about dietary modifications that can significantly help your bladder function. So I've had great success with people doing these things when they have early on overactive bladder or trouble emptying their bladder. Discontinuation of artificial sweeteners like pink, yellow, and blue packets for your tea and your coffee. Green, which is stevia, is probably okay. Abstaining from or reducing caffeine and alcohol intake, which really irritate the bladder, and reducing sugar intake. Increasing fiber to help your bowels. Drinking water, which you might say, well, gosh, then I'm going to have more of a problem with my bladder. Well, there's an old nursing adage that says if you sip, 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 you drip, drip, drip. So my advice is drinking larger amounts of water in less frequent intervals during the day. So you can practice timed voiding. If you drink, an 8-ounce or a 16-ounce serving of water in a 15-minute time period, then in an hour, you'll have to use the bathroom. If you drink that same 16 ounces a little bit at a time over 2 hours, you're probably going to have to use the bathroom a lot more. So getting that water in can be done, and it can be done in regular intervals so that you know when you have to go. Moving your body helps you go to the bathroom. Moving your body helps you poop. I mean, that's as simple as it is. And it can be any type of movement. If you're sitting, get up. If you have a hard time getting up, have someone help you with moving your legs around. Twist your body if you can. Do anything to get those bowels stimulated and moving. And the other things that have good evidence for bowel dysfunction and pelvic floor and bladder issues are yoga, acupuncture, and breath work. You might say, well, why breath work? Well, constipation is really strongly associated with stress and anxiety. So if you learn how to deep breathe, your neck and shoulders and your chest isn't the only thing that relaxes, right? Similarly, many people have an anxious bladder. And they might have to go to the bathroom, say, well, it's time for me to go out. I have to go to the bathroom now, when you really don't have to go, but you just kind of get stuck in these habits. So practicing deep breathing can help with these things as well. Depression and anxiety. Depression and anxiety are perhaps the most difficult things to talk about right now. And I say right now because it is extremely difficult to get in to see a mental health provider. There is a lack of them right now, and there is an overflow of people who need them. And so I think it's really important to just keep talking about it with your healthcare providers, that you can see if it's a problem for you. Again, depression and anxiety can be caused by other things that we've already talked about. Like I said, you'll see lots of similarities here. We treat these with medications like SSRIs and SNRIs. We might also make adjustments to your current medications, which could potentially cause depression or anxiety, and refer you for counseling. Other things that you can do include, look at this again, improving nutrition, moving your body, getting outside, practicing grounding. How many of you know what grounding is? I've had more people ask me about this in the past 3 weeks. Then I think it's so cool. So basically the theory behind grounding is that there's some sort of electromagnetic energy in the ground, in the earth, that makes us feel better. And when we walk around barefoot, it's good for us. Well, not everybody can walk around barefoot, especially if you have balance problems and, things are uneven. If you can't, or if you don't have access to a place to walk around barefoot and enjoy the day every day, well, you can get a grounding mat now. You plug it into the center part of the outlet. It doesn't have a full, 3-prong thing. It just goes into the center part of the outlet. Put your bare feet on it for 10 or 15 minutes a day. If you're like me, you might feel a little bit of almost like a mild TENS unit kind of thing from it. And it helps stimulate a sense of calm in the body. Mind-body therapies and manual therapies are also helpful. And then spasticity is managed with muscle relaxants, physical therapy, potentially the baclofen pump and or Botox. And then from an integrative standpoint, we bring in hydration, we bring in bowel and bladder management. When you have a UTI or you're constipated, your spasticity tends to be worse. We use physical therapy, we recommend yoga, and then manual therapies like massage and acupuncture. So Dr. Sanders talked about biosimilars, and I'm going to talk about biomarkers. So what's a biomarker? A biomarker is a test that improves diagnostic sensitivity. So it helps us to know that what we're treating is really the right thing. It predicts disease progression and or improves outcomes, because sometimes for certain things like cancer, it directs us to the targeted therapy for the person. In MS, we've had biomarkers for a long time. We just don't necessarily think of them as such. Most people, when they think of a biomarker, they think of a blood test. Well, biomarkers in MS that have been around forever are things like OCT or optical coherence tomography. It's easy to do. It doesn't hurt. Cons are access. Not everyone's insurance pays for it, or not everyone's eye doctor does it. We've had LPs forever, for long before we had MRI. Lumbar punctures, what we do with those is we look for proteins called oligoclonal bands and high IgG levels. They're present in about 90% of people with MS. The cons of a lumbar puncture is that it hurts, right? And sometimes people get spinal headaches afterwards. And sometimes these things that we're looking for are also present in other autoimmune diseases. So they're not 100% specific to MS. And then we have MRIs. MRI is probably our most frequently used biomarker. And within MRI, more specific biomarkers are T2 lesions, which are the snapshot of your MS history, gadolinium enhancing lesions or active lesions, brain volume, and then there are other biomarkers being developed and used more frequently, like MR spectroscopy, MTI, and DTI. The pros of MRIs is that it's easy to see, right? Like it's literally something you can look at. It's easy to follow because we see changes over time. The cons are that we're not necessarily seeing all the changes. And also they're expensive. Also, many of you hate them. Many of you just dread, like, do I have to do this every year? Also, brain volume is not always measured the same way, and it's not measured in a great way in the community. It's measured in a much more specific way in a research setting. There is narrow access to advanced techniques like NeuroQuant, which is and there are other types of similar software programs that can match your brain next to someone of your age and sex and see where your brain volume compares to theirs and actually count your lesions. When you guys ask us to count your lesions, it's near impossible for us to do it. We see one big spot, and when NeuroQuant looks at that one big spot, it might say you have 40 lesions in there. So, so it's hard to do that. The programs like NeuroQuant help to do that. MTI and DTI are other newer techniques that not every imaging center does, nor does your insurance always pay for it. So sometimes imaging centers will say, hey, we'll throw this in, we're testing it out, we'll eat the cost. But it's not something that everyone has access to with every MRI. High-strength magnets aren't always available. We love 3T imaging, but not every imaging center has a 3T magnet. And then you guys, because of your insurance and convenience, bounce around to MRI centers. So somebody might go to a hospital one year, and the next year they go to a freestanding facility, and the next year they go to another freestanding facility. And then every one of those facilities has a different magnet strength, and nobody took their CDs to the other facilities. And so the comparisons aren't real good. So those are the downsides of MRIs. And then we have serum tests. So these are what we usually think of when we think of biomarkers. Blood tests. Currently available blood tests commercially are neurofilament light and Octave's MS disease activity test. Pros, fairly easy access. Cons, confounding factors. And neurofilament light on its own has many of those, which is why I'm primarily going to talk about the MS disease activity test. So it was developed by Octave Bioscience. It measures 18 proteins in your blood that are specific to the central nervous system and sensitive for inflammation that occurs there. Each of these 18 proteins also changes with other disease states, which is why one of them on its own might tell us something about MS. But if you also have diabetes or obesity, or have had a stroke or a TIA recently, or maybe a concussion, things might go up and down. So what we do with the MS disease activity test is we take these 18 proteins, put them through an algorithm, and what comes out is a low, moderate, or high risk of disease activity in the next 60 days. And what that is essentially a new MRI lesion. So it's a snapshot in time. It's not telling us, what's going to happen over the next year, but it's certainly either reassuring about what we're doing right now or actionable, particularly if it correlates with something that's going on in your body or your MRI as far as what we might do with your disease-modifying therapy. It looks at 4 different categories of proteins, and those categories are immunomodulation, neuroinflammation, myelin biology, and neuroaxonal integrity. And within those categories are what I would call hot topic biomarkers that you're reading about on MS News Today and things that you get in your inbox and blogs. So those hot topic biomarkers are NFL and GFAP. Higher levels of NFL are associated with relapse, with MRI activity. Lower levels are associated with being on a disease-modifying therapy, and higher levels are also associated with higher levels of disability. Now, NFL on its own, as I mentioned, has a lot of confounding factors. So when I look at doing anything for a person, I look at not just the test that we're doing itself, but also the risk-benefit ratio. And when I look at a risk-benefit ratio, I also look at cost. And for me, the amount of information that's available on the MS disease activity test is well worth the minimal cost because Octave has a program to help you with payment that's household size and income based. Medicare, Medicaid, and TRICARE cover the lab. So it's a really great way to get additional information. It empowers patients and providers like Dr. Sanders and I to be armed with more information to help you make better personalized treatment decisions. It does not monitor progression or diagnose MS. So people will say, can this tell me if I have secondary progressive MS? No. What it tells us is that in the next 60 days, your risk for disease activity is low, moderate, or high. It's based on a score. Low score is low. Moderate means you're about 4.5 times more likely to have disease activity in the next 60 days than a person with a low score. High means you're about 21 times more likely than a person with a low score to have disease activity in the next 60 days. So we follow that over time. If your score is low and you're doing well and everything's going great and you're on your disease modifying therapy and we check your score the following year and suddenly it's moderate or high, we might say, what's going on here? This is the report that you get from the MS disease activity test. Basically, on the right, you see the circles. The circles are the biomarker pathway categories, the immunomodulation, the myelin biology, those sorts of things. And then these are the 18 values on the far right that you get and can follow. And so when Dr. Sanders and I look at those values, we're reading things that are studied in basic science research, in MS research that's just looking at serum and cerebrospinal fluid biomarkers, and following those things over time. It's interesting to see that, well, gosh, there's NFL right there. Is it going down? If we've checked this in a patient with newly diagnosed MS and the NFL level is high, we want to see after that person has started on disease modifying therapy that their MS disease activity score goes down. It would also be nice to see that NFL go down because we know that that's another marker that's been scientifically validated and it's part of that test. So that is it for me. And I think we'll take questions now. And my overwhelming, I guess, goal is if you change your habits, you can change your life. I think we all talked about that tonight. Jeff mentioned making goals, moving your body. Dr. Sanders talked about microglia and neuroplasticity and how important it is to change the way your brain works so that you can change the way your body functions. And hopefully you can take some of that away into the holidays and have a really amazing holiday season and not come out on January 1st like, oh God, what am I going to do? My resolutions are overwhelming. Make your resolutions less overwhelming this year.
Thank you very much, both Dr. Sanders and Dr. Weigel, for doing this.
Okay, my question is, I have had MS now since 1998, and the cost of the medication has not gone down. It has gone up exponentially. And so it seems like medication that was developed that long ago, based on looking at the track of other medications that are on the market, why is that? And will we ever see any relief?
It's an interesting thing about the market for MS disease therapies. You are right that the more that comes onto the market, the prices go up. That kind of goes against economics, right? We now have several generic medications that are available that can help to defray some of that cost. There's generic teriflunomide, fingolimod, there's glatiramer acetate, and then there is dimethyl fumarate. And so those are available if you are on the branded medication. Now, the question it sounded like was, why hasn't my disease modifying therapy gone generic? And I don't have the answer to that. But what we do know is that there are resources that are available for many people if cost is an issue.
Going a step further for that, 1 second, maybe both of you can answer this. What do you know, with what you know about the biosimilar that's soon going to be coming out, how do you feel the cost of that might be? Biosimilar for natalizumab.
So let's say also that much of this depends on your insurance company and the deals that the pharmaceutical companies make with your insurance company. We've both been to Capitol Hill to advocate for generics, safe generics and biosimilars for MS. And we got them. The problem is it doesn't necessarily mean that they're cheaper, because your insurance company and your even Medicare can say, well, you have to have the generic, but now the pharmaceutical company is off the table, so you don't get copay assistance anymore. So actually your cost for the generic is not receiving any help, and therefore there's more out-of-pocket cost. Mark Cuban's pharmacy, Cost Plus Pharmacy, or is it Cost Plus Pharmacy.com, has generic teriflunomide, generic dimethyl fumarate, no injectables, and fingolimod too, and generic fingolimod. And the costs of those drugs go between, I think, $10 and $18 a month. even if you have insurance. So you don't have to use your insurance, you just get your prescription sent there. So that can help defray some costs. The why is also economics. It goes against sensible economics, but it's this kind of economics. Yeah.
I think Tyruko, my understanding is that they're hoping to price competitively, and so help to hopefully potentially drive the market down, but we'll see.
I have two questions. The first one's for Megan. Do you think there is a difference between fatigue and sleepiness?
Yes. Many people with fatigue have sleepiness too, but typically MS fatigue is not significantly relieved by sleep. People don't take a nap and their fatigue's gone. Sometimes they do, but that's one of the reasons we try to rule out sleep disorders and treat any underlying sleep disorder. But the fatigue in MS, I feel like everyone's in here is at least our age. So like, remember when you would unplug your TV, like the old time TVs, and the color would just like, and it would turn off. I feel like that's fatigue in MS, and that's not sleepiness. That's just like, I can't go anymore. So I do think it's different. You want to?
Oh, I agree. I think when it comes to MS-related fatigue, which we call lassitude, it's kind of a short circuiting of your nervous system. And so it's like Megan mentioned, you will hit a brick wall. And that fatigue is not just alertness, but also motor fatigue. So it's not that you can't stay awake, it's that your muscles will no longer move the way you want them to.
Okay, second question. A patient who was on Lemtrada 10 years ago-ish, would you recommend they take the Octave blood test?
I recommend that any patient, regardless of disease-modifying therapy, can take the Octave MS disease activity test, definitely.
If a person is not showing any disease activity at all, and they actually feel like they might be feeling better now than years ago when they were diagnosed, should they still take that test?
Would you still get an MRI?
No.
Okay. Well, then you might not want to know what's going on. So
I have no idea.
So we would use it. We would use it as a biomarker, right?
Sure.
So as a look at how your MS is doing. And one of the things that we use MRI for is, I look so good, I feel so good, I haven't had a relapse in years, I don't want an MRI. And then we get an MRI and we look back and there's all these new lesions, or there's been a bunch of brain atrophy. And so things in MS happen under the radar. They don't always show up in your body.
So when doctors are saying now that you should have an MRI once a year, are doctors going to be saying you need this blood test at least once a year?
I think things should be taken as a composite. So the MS disease activity test will not stand on its own. I don't think solely based on it will I make decisions on your MS therapy or what we should do next. But I will put it in context with your MRI activity, your clinical symptoms, and your progression status.
Staying on the same line with the blood tests, because we do so many events in rural America, we hear and know that people out there are not learning about this. All right, their doctors are usually just doctors. Some of them are neurologists, but they are very, very general neurologists, and there's too many things on their plate, and they really don't want to learn about anything new. So what can you tell to those that are living in truly rural America that need the help and how they could convince their doctors that this is something that they should be doing?
There's not much convincing to do. I think that you just need to know how to get the test ordered. So if you're living in rural America and your doctor doesn't know about it, or your doctor wants more information, they can go to octavebiosciences.com. They can watch the MS Views YouTube channel and take a look at the panel that we did, myself and Dr. Mitzi Williams and patient advocate did on the test itself. And depending on where you live, different labs are drawing the test. So this isn't a test that you can have done at like Quest or LabCorp, but it can actually be drawn in your doctor's office if they have the Octave kits, and that's something your doctor's office does. So a person can simply go on the Octave Biosciences website, call the 1-800 customer service number, get more information, or ask their doctor to do that.
Great, thank you. Straying away from that subject for a minute, but staying with rural America. And by the way, you all are not in rural America over here. You might think you are because you live in Green Cove or something, but seriously, you got I-95 so close to you that I don't even know what to say about that. When we do our programs in rural America, sometimes it's 3 flights to get there. I mean, it's just insane, all right? So a person from that portion of the world sent in a question: how might it be, because it is so far to get to an MS center from where they live, how might it be possible to get nurses possibly to come to their different areas to see people on like a once a month basis?
Great question. Not being in a rural setting, it's hard for me to answer that question. But what I will say is that there are potential resources with programs like ECHO MS, which is with the National MS Society, where hubs are able to facilitate care with satellite facilities in different areas. And so I would recommend contacting the National MS Society MS Navigator program to inquire about that. Obviously, the resources have to be there, and the facilities have to be there to actually send the nurses out.
Many insurance companies also offer case management for people with chronic illnesses, and sometimes they'll offer it, and sometimes you have to ask for it. So I would encourage those people to contact their insurance company and see if there's case management available to them, and oftentimes they can facilitate services that aren't readily available or obvious.
Great, thank you for that. Somebody else wrote, what can you explain TIA? I have no idea.
Oh, I'm
what
sorry. I did say TIA. It's a transient ischemic attack. So, and sometimes it's called a mini stroke.
Okay, thank you. And another person is asking...
Has nothing to do with MS, by the way.
Okay. And another person is asking how they can get help paying for their MRI.
The MS Association of America has an MRI fund. You go to their website. I think it's How Can We Help tab, or very similar. There's an application that you can either print out or fill out online. There's a little part for your healthcare provider to fill out. They will pay for the cost of a brain and or a cervical MRI. Whether you're about to do it, they will also pay for it retrospectively. In the past, they just won't pay for as much if it's retrospective. So MS Association of America, mymsaa.org.
Okay. Now the person is asking that they've heard that there's 7T imaging out there. What can you say about this?
So 7T imaging is where we're getting all of this valuable information about smoldering MS and what these chronically active lesions look like. Unfortunately, they are not available everywhere. They're oftentimes in research and academic centers. We actually do have a 7 Tesla magnet here in Jacksonville. It is housed at Mayo Clinic. But my understanding, even their doctors can't order 7 Tesla magnets on everyone, because there's still a lot of validation and things that are needed to use that more consistently.
Okay, thank you. Next one. Can someone explain the difference between a PET scan and an MRA, and why would one be ordered over the other?
MRA or MRI?
It was written as MRA.
So a PET scan is a nuclear medicine test that looks at a particular target. So PET scans, depending on what you're looking for, a nuclear medicine is given and it travels to the area. So for the PET scans that I discussed with the newer nasal spray is targeting microglia. So they're injected with a target or a marker that travels to areas of microglial activation. And so that does not give us very much, if you remember in the picture, not much with the structure of the brain. It's more of a functional type of test. And so the MRI using magnets can give us a great picture of the structure of the brain. So they're testing different functions and have different valuable information.
And the markers are different according to different disease states.
Okay, thank you for that. Next one is asking, well, the person repeated that it was MRA and not MRI.
So MRA imaging is magnetic resonance angiography. It's looking at the blood vessels of the brain, not the arteries specifically, not the parenchyma or the structure of the spongy stuff in the brain. So I'm not sure why someone would be looking at to order an MRA versus a PET. That doesn't make sense to me.
Okay, thank you.
Or to Dr. Sanders, because she just nodded at me that she agreed.
Have you heard about cognitive markers? Cognition markers. They were at Ekstrom's recently in something called ViewMind. It's a new way, instead of somebody clicking a device, it actually follows your eyes to what you actually see on the screen. So that way, if your eye is not finding it, which is quicker than your finger touching it, that they could see where there's actual cognitive problems happening. So you'll know more about that soon because we're interviewing them soon. So.
Wonderful.
Awesome.
Wonderful.
I'll look for that video to learn
good.
more too.
Great. Next, they wanted to know more about MSDA knowledge. I don't know what that means, but that's all that was written.
Well, let's just refer them to the YouTube. Does it have a specific name, Stuart, on the YouTube? Is it
It's Octave's Blood Biomarker or something. I don't know.
Yeah, so on the MS Views YouTube channel, there's I think it's either 1 hour or 90-minute webinar that's specifically, the whole thing's about the Octave test. And so I would encourage you to watch that.
Great. Thank you for that. Next, what is the cost of the Octave test?
So the cost if you have Medicare, Medicaid, or TRICARE, it's free. If you have commercial insurance, there is the Octave Promise, which is based on your household size and your income, and it could be anywhere from $0 to a maximum of $149, just depending on what that cost is, on what your household size and income are.
Okay, thank you for that. And next person is saying that they heard that there was a rejection to one of the BTK inhibitors being studied, and they want to know if you could speak more about that.
Sure.
And why?
So as I mentioned earlier in the talk, evobrutinib did not, in its initial evaluation or analysis of its data, did not meet its primary income. I need
Nobody does that anymore.
No one meets their primary income endpoint. So what the study was looking for, there was 2 phase 3 clinical trials looking to see if evobrutinib reduced annualized relapse rates more than teriflunomide. And they found that both groups had very low annualized relapse rates, but there was no statistical difference between the 2 groups. And so because their primary endpoint was to show superiority over teriflunomide, they have preliminarily said that they did not pass their test.
Great, thank you for that. Going back to what you were saying before about the Octaves program on the MS Views channel, it's called Watch, Listen, and Learn about a blood test biomarker to measure and manage your MS. Okay, thank you. All right, going back to the questions. A person writes, during BTK trials, how can they determine improvement for smoldering MS?
So the way they look at smoldering MS is currently through a disability assessment called an EDSS. And essentially what an EDSS is a neurological exam, very detailed, and the person has to walk 500 meters. And depending on their performance on this evaluation, they're given a score. And that score is measured over time periodically throughout the trial. And so from point A, they can determine whether or not a person's EDSS score decreases or increases at the next time point. And so that's how disability progression is measured over time. Currently in clinical trials, we're still starting to hash out, and maybe PET scans may be used in the future to determine whether or not it's truly because of smoldering MS.
Okay.
And it's my opinion, and since this is an MS Views talk, we're allowed to say our opinions. It's my opinion that these clinical trials for BTK inhibitors might not be long enough for us to tell what their actual benefit might be, because smoldering MS takes MS, let's call it progression, takes a long time to happen.
So going back to the BTKs, did you get a chance to mention how many there are being studied?
Yes, there are 5 BTKIs.
Does that include the one that was just rejected?
Correct.
Okay, thank you.
And it has not been officially rejected. It just, they put out a notice that they did not meet their primary endpoint. They still need to do all their formal analysis and talk with the FDA. And we have seen with other therapeutics and other disease processes where the clinical trial did not meet their endpoint. And then with further discussion with the FDA, re-looking at the data, they found that there was some benefit and has led to conditional approval.
Thank you for that. Next, can you talk about pilometric movement and spasticity?
Plyometrics?
It says pilometric.
It's probably plyometrics.
It could be plyo. I can't read it.
Plyometrics are, I always get confused. Are they like the jumping things or not static movements, but more like, not squatting, but a squat jump. That kind of thing is a plyometric movement. Are there any exercise specialist PTs in the room? Yeah, like box jumping and things like that. So can those be helpful for spasticity? So exercise is helpful for spasticity. It depends on the level of spasticity, and also like the environment. Are you in a cool environment? Are you well hydrated? Imagine if you're jumping and your spasticity gets worse, then you're likely to fall or hurt a hip or a knee, or maybe not be able to extend your leg as well. So I think plyometric movement should be done, if you're new to it, in the setting of an exercise therapist or a physical therapist.
Thank you. Any questions? Thank you. Sorry, I can't run though.
What is y'all's opinion around more like Eastern holistic medication? For example, medical marijuana, mushroom dosing, etc. As you mentioned, there's a comparison with fatigue and depression. Medical marijuana would help that.
So I didn't talk about medical cannabis, and thank you. It just was not on my radar when I did the talk, literally. But medical cannabis has been studied in MS, and what it has been studied for is not everything. So I say this with a grain of salt, and also the studies, they've been done a few years ago. So what it has been helpful for in MS that's been studied is spasticity, neurogenic bladder, and neuropathic pain. Can medical cannabis help depression and anxiety? It certainly could, depending on the person. It could also make both of them worse, just like our medications can. There's no way to advise you. Like people come in and they say, well, I've got my medical card. What should I get? So there are 2 types of cannabis. There's indica and sativa. You can remember that by indica as like Indicouch. So it's the kind that makes you sleepier. And so many people will use that at night to help them sleep. If they use it during the day, it's just a little too slowing. And so we tend to advise accordingly. But then when you go to the medical cannabis dispensary, you might find something you like, and then it's not there next time you go. There's a lot of trial and error. So just keeping those things in mind, but it can be very helpful, depending on the person. The amount of THC is what determines the psychoactivity of the medication, of the cannabis. So I tend to recommend really high CBD to THC ratios. So more CBD, less THC. That also makes it more expensive.
I would also like to add that in those clinical trials, although they did show benefit in reducing spasticity and pain, cognitive side effects was also seen. So we have to balance the risks and the benefits, just as we do with any therapeutic.
And then medicinal mushrooms, you're referring to like psilocybin type stuff. So psilocybin research is in its infancy. It is a growing I don't want a phenomenon, maybe. Like there's a lot of research, nursing research done with psilocybin. But all of the research that's currently available that's done in a very good scientific way is done in cancer. And quality of life and sense of well-being. So we can't really extrapolate that to everything. Medical mushrooms are illegal. They are legal in Denver, Colorado, in the sense that if you get pulled over with them, you can't get arrested anymore. And that's about it, unless you're in a research setting or a part of, there's one very big group of therapists and psychiatrists that perform very rigorous research that you can be a part of if you're interested in those things. So I think it's in its infancy and is definitely, having this discussion in 3 to 5 years, I might be able to say a lot more things about it because I do think plants are medicinal, but we just need to know how they are, keeping in mind that most things in nature are balanced. Just naturally, they're balanced. And so when you take pieces of nature and then put them in solitary confinement, they do things that they weren't intended to do in nature. So we just have to be careful with what we use and how we learn to use it.
So what about, you often speak about lion's mane.
So I feel like I'm often asked about lion's mane.
Okay, what can you tell us about lion's mane?
So I speak about it because people ask about it as far as lion's mane's a mushroom, not a medicinal mushroom. It's, it's not going to make you hallucinate. It's a, I guess it could, it could be medicinal. It's not a hallucinogenic. It's similar to like a reishi mushroom or I can't think of other types of mushrooms right now because I'm hungry, but I love mushrooms, so it's making me hungrier. But lion's mane is a mushroom that has been touted for its anti-inflammatory properties, potentially for having properties as an anti-inflammatory that properly address your immune function. It has been said that it can help with diabetes, that it can lower blood pressure, and particularly in MS, that it helps fatigue. And so many people don't know that there is quite a bit of research done with natural medicines. There's a natural medicines database that's like the PDR for natural medicines. The Germans have a monograph that's like this thick. And there's a lot of research. And so the only research that has been done with lion's mane and fatigue that all of this came from is a study done in mice that showed that mice that took in lion's mane swam faster in their little pool. So that is where all of this came from. And so if you take lion's mane and it works for you, that's really great. If you take lion's mane and you have diabetes or hypertension and you take medicines for those things, there could potentially be lowering of blood sugar or blood pressure. So you should watch those things. And you should never stop medications for things to move to supplements without talking to your healthcare provider. So lion's mane is helpful for some people. And then if you're just using it because you think it might be good for you, we don't have two of you to know if it would be, like 20 years down the road. So, if you don't have side effects from it and it's affordable and it comes from a reputable source, it might be safe for you to take.
Is lion's mane also used for cognition?
So again, no research in cognition, but do people take it because they think it's going to help them? Yes, they do. Great. Do I recommend it for that? No, because there's no research.
Going back to the THC, many doctors tell their patients that they don't want them to be smoking it. They'd rather them do gummies. What is your feeling on this?
So there is good quality research that dates back probably about maybe, 5 to 7 years that says that smoking marijuana impairs cognition in MS. Taking any kind of THC can potentially impair cognition, whether it's inhaled or eaten. One of the problems with gummies, thanks Stuart, one of the problems with gummies is that depending on the effect that you want, a gummy takes some time to metabolize depending on your age and your body composition. And so people tend to overtake gummies because they don't think they're working as fast as they should. And then they end up with a lot of THC, a lot of psychogenic effect. So there's a lot of jury that's out with what's the safest way to recommend medical cannabis. I don't know that I'm answering your question.
So smoking it wouldn't affect the lungs?
Yeah. I mean, we don't recommend smoking.
Exactly.
Yeah, for sure. Vaping is the quickest way to get the effect of the cannabis. However, we also don't know what vaping is going to do to your lungs over time. So, jury's out.
Thank you.
We do the best we can. Yeah.
Thank you. Any questions? Then I'm going to say goodnight and thank you very much for being here.
Thank you, guys.
Thank you.
Thank you all for being here. Wait, I got to let you all know something. This is our last Compass MS Care program for the year. And I have to say, congratulations, Stuart. It's 25 years since being diagnosed this week. And I'm still here walking and doing and doing and doing and doing. Thank you to the medical world.